right now, there aren't a lot of drugs for dementia. The big ones like Aricept and Namenda, which are pretty much given to any of your clients who have the major dementias that I had listed, Alzheimer's, Lewy body, or vascular. Let me show you how they work. All right. Dementia can go in any type of direction. It could be chronic and progressive, incrementally getting worse and worse over time, or we could see a plateau, a level of loss that stays at the same baseline for the rest of someone's life. But if it is a declining type of dementia, it doesn't decline at a steady slope. It kind of happens in milestones. There we go. In steps. Reisberg, Ferris, and Crook in the early 80s had found that people lose skills in the reverse order that they developed them when it comes to dementia. And he calls this scale the global deterioration scale. And it's probably wise to know what the scale is, because your electronic software might be asking you what's your client's approximate GDS. We're not getting into staging in this class, but if you do go on my website, click under tours, they'll say links to cognitive assessments, and you can get the link to the brief cognitive rating scale, which you could administer to determine your client's GDS score. The levels of the scale, there are 7 levels, and we'll be talking about levels 4, 5, 6, and 7 today. 4 is early stage dementia, 5 is mid, 6 is late, 7 is end stage. But go online and look a little bit more on staging, because it could kind of give you an idea. But so people lose skills in the reverse order that they developed them. There are approximate age equivalents for how the client processes information, and it gives us a good guideline on how to present information and teach our client at their cognitive level. The difficult thing is we never, ever tell the family, hey, he processes information like a 5-year-old. You would never say that to the family. They wouldn't hear you. They would just hear blah, blah, blah. She just said my dad's a 5-year-old, and you blow the rapport. Never say that. Yes, ma'am? Reisberg, R-E-I-S-B-E-R-G. Yeah, and the link's on my website under cognitive assessments. And then the theory is called retrogenesis. So 4, we're saying kind of like an 18-year-old, and all the way down to 7, we see at the end stage of dementia, people are contracted in the fetal position, showing primitive reflex patterns like routing, tongue thrusts. Last word people ever speak is mom. That's the most common last word. Isn't that interesting? All right. Mom. It's the most common last word. Okay, so the stages. Now, when someone gets diagnosed at a GDS of 4, that's when they would be put on a cholinesterase inhibitor, and then what that does is it delays the process of the dementia, so they end up having a longer baseline. So maybe for about 6 to 9 months, they stay at that level of their dementia instead of progressing on. And then they continue to take the drug as a long-term prophylactic to prevent symptoms from getting worse faster. Because if they get off the drug, their cognition will drop to where it would have been had they not been taking the drug. It's like a shield. It keeps me from getting shot for about 6 to 9 months. Take the shield away, you get shot. Put the shield back, it only protects you from further damage. Then you have, so that's Aricept and the Exelon patch, which are cholinesterase inhibitors. And then you have Namenda, which is an NMDA antagonist, which is a glutamate antagonist. And when taken in conjunction with, drugs like Aricept, you see a little longer respite of symptoms. And really, there's also the phase 3 human clinical test trials, which are kind of exciting. We see a little bit of boost in cognition, and then a longer plateau. So it looks like, and that's been taken in conjunction with those other 2 drugs, the future of dementia looks like our clients are taking a very expensive drug cocktail to kind of delay the effects of the disease for as long as we can. So it's more like a preventative. Yeah. For the Aricept, yeah, and that's the big one. So the delay is about 6 to 9 months tops, even if you double the dosage. Mm-hmm. Well, some of the ones that are in the studies, they're seeing it's variable. If they are taking the Aricept, it could be another 3 months on top of it. So I mean that's 9 months. That's a lot of savings, and we see for Medicare spending. I mean, if we think fiscally, but also humanistically, mom gets to stay home for another 9 months. So is that worth the price? And then in the future, hopefully we have enough drugs that we could just delay, and then hopefully she dies of something else that isn't so horrible. No, the only real side effect for Aricept is constipation, and that's why they might have the Exelon patch. And I don't know about the phase 3s. The Namenda, that's glutamate, so your brain's full of glutamates. I haven't seen any big negative effects with any of those drugs. But no, not really getting in. There's no big side effects for those that we know of so far. Maybe we don't have a long enough longitudinal study. And then there is a new drug that is helping with excessive emotions like crying. And I don't remember what that's called. Do we have any nurses in here that know what that's called? Do you know? Anyway, it's treating a midbrain impairment, and that drug is actually used to make the diagnosis of whatever the midbrain impairment is, because if the drug works, then we know why. But that's all I have about drugs for you. All right, so the nursing home has over 400 F-tags. That's more federal mandates than nuclear power plants. And, I feel bad because, if you work in nursing homes, you probably have a permanently startled expression on your face. Like you're probably a little on edge. But really, there is room for creative interventions. Like I said, that's where I work most of the time is in nursing homes. And it just takes a lot of patience and love, but we can get these programs in. Acute care, you might feel like you're having a little bit of a hard time because you only have them for about 3 days. What can you really do creatively to help? I think your role will be very important for staging. Definitely get into the mini-mentals so that we could get the diagnosis for the client if they've never had the dementia label. That is actually very helpful for the family. Unfortunately, dementia has a stigma, and we avoid saying it, but I think the more we label it, the less of a stigma it's going to have. We just need more celebrities to stand up and say, just because you have dementia, you're not dumb. Look at Pat Summitt. Thank you, Pat Summitt. We need more people to speak out. Assisted living facilities, you're the new skilled nursing facility. You're having to get adaptive equipment that you didn't use before, transfer equipment that was against your policy, like lift machines and slide boards, and helping people get to their dining room for their room, which are not things we used to do with assisted living. So we're changing the way that we do things. We're realizing that if we want to have a longevity of our company, that it's important to provide a tiered level of service to help people age in place. And perhaps you also have a memory care unit where you work. So you're changing. Skilled nursing facilities, you're the new acute psych facility. You know, how many people are we admitting with psych disorders, like anxiety disorders, but they came in on an AFib? You know, we also have home care is the fastest growing industry. Who's working in home care in here? Oh, good, good. It's so nice that people let us in their homes, huh? You know, we're learning that people can live at home with surprisingly low cognition, which is very shocking if you used to work in skilled nursing facilities where we're more protective and worried about that. Home care, you might be going to assisted living facilities too, so you probably see that environment. You might do the home cares also work in hospice? You do hospice too? No? Do you do hospice a little bit? Does anyone in the room do hospice? So we'll talk about end stage today. Anyone work with someone who's dying, like with dementia, end stage dementia? Okay. So hopefully I can give you some sensory ideas and goals in that section. Anyone work at adult daycare? Anybody? Anybody a therapeutic driving instructor? Because that's a growing thing right now too. Not a lot of competition in that job market. Yeah. No? All right, there's a big push from the government to do collections of outcomes measures, perhaps through standardized testing. Maybe you have to do the BIMS or OASIS, GDS, MISIS stuff. ROCS software is kind of guiding us to do collections of data. But you might want to collect your outcomes on a case-by-case basis. Client will demonstrate safe transfers, 8 out of 9 observed transfers, and then we just do the repetitive sit, stand, sit, stand, sit, stand, and see if every day we could increase the competency with the transfers. We wouldn't call that repetitive training. Third-party payers hate the word repetitive. Behavioral training, behavioral practice, sustained practice. Those are words you could use. I love client will demonstrate willingness goals. That's a good one because they really have a case of the don't wannas. Client will demonstrate willingness to wear appropriate footwear to therapy. 3 out of 4 sessions. Client will be able to articulate 3 energy conservation tactics to prevent fatigue. You know, just really specifically measure. And then, you know, every day you ask them, what are some things you could do to save your energy? Demographic information you may also be collecting, and as I said, home care, you're having to collect the falls information now. So, but I will show you some assessments out there. In general, this is all I have to say about drugs for this class because it is a non-pharmacological class, but I do want to at least have a little background for you as to why we may want to do this class. Pharmacological treatments have very limited effects on certain behaviors and may have serious side effects for older adults that have dementia. There was the Haldol study. There were several Haldol studies in a meta-analysis on the Cochrane database of systemic reviews published in 08, 09, 10, 11, 12. Haldol is a no-no, just especially with Lewy body dementia. They respond poorly to any antipsychotic medication. It could severely increase any of their symptoms, which include variability in function. We already see variability with Lewy body dementia, like the person might need sternal pressure to wake up in the morning, max assist to do an ADL, and what are they doing by nighttime? They're walking around carrying their mobility device, saying, I'd walk a lot better if I didn't have to bring this with me all the time. That's variable. You add Haldol to that, an already variable person, and we may have more aggression, psychotic symptoms, or even maybe another time during the day you have to give them sternal pressure. I've seen some Seroquel studies. They're mostly inconclusive, but some nurses swear by Seroquel over Haldol, but in general, Lewy body dementia, it says on all of the medical pamphlets and paperwork, responds poorly to antipsychotic medication. I don't know how many times I still see doctors prescribing Haldol for clients who have Lewy body dementia, and I'll present the study, and this one doctor I was working with, he's like, Haldol's cheaper. That's what he just told me. Haldol is cheaper. And what do you do when you have masses of people to care for? Hate to mention words like apartheid, but that's pretty sad. I don't think that's good. If we know that Haldol's bad and we're giving Haldol, we shouldn't. All right, we also see very serious side effects for older adults who are also being treated for depression. Why? Because a lot of depression medications have side effects of fatigue. You add antipsychotic medication on top of that, another drug that has a side effect of fatigue, then you have a lower cognitive status. So psych nursing strongly recommends keeping your client on under 6 meds who has dementia. That is a very lofty goal. How many of your clients are on more than 20? Yeah, that's a lot. That's a lot. All right, but I have seen good studies on clients who are taking multivitamins, B-complex, omega-3s. I've seen good things on those studies, on vitamins. And on the Namenda and the Aricept, but that are published. We do not see any drugs for vocalizations, agitation, wandering, and passivity. The only drugs I've seen that seem to be working for vocalizations were NSAIDs, pain medication like Tylenol. So that was able to reduce vocalizations, giving someone some Tylenol, because that might tell you the need driving their behavior if Tylenol was working. What was probably the need driving their help me? Pain. All right. So that's what we have. And dementia in general, I mean, there are so many of them, but they do have some common weaknesses. They are a forgetful sort. That is, number one, a symptom that we see with dementia. Kodama and his team of researchers in Japan, Kodama, had found that everyone who has a dementing illness has hippocampal atrophy. The hippocampus is inside of your midbrain, and it is responsible for short-term memory and working memory. And everyone who has an irreversible dementia has hippocampal damage. So we see strong ties to the memory loss with atrophy of the hippocampus. Guess I won't show you on here. I'll show you on my Human Brain Atlas in a minute. I don't want the mouse atlas. If you see a mouse brain, that's not going to be helpful. All right, we'll see what happens. Maybe it just lies. All right. We also see some sort of brain atrophy, and it could be any region of the brain. So we definitely see hippocampal atrophy. But you may also see global cerebral atrophy, so atrophy of the entire brain. And I say a good layman's term way to explain this is the brain's kind of like an ice sculpture. With dementia, once the ice sculpture starts to melt, what's the first thing that you lose? Details, right? So short-term memory, recent kind of stuff, that's what happens most of the time. And then things that happen within the last few months, last few years, and then eventually the long-term memory goes. Usually the long-term memory stays pretty intact, and I can vouch for that with pretty much every dementia except for vascular, because that's really going to depend on localized damage. Difficulty with new learning. We do not see a lot of plasticity, which is the brain's ability to change. So learning that toe-touch weight bearings, trying to put your foot on an egg and you don't break that egg, that's going to be hard for them to learn. They are kind of a non-compliant sort with their precautions. I usually don't say non-compliant, though, because that usually means, hey, I can't change him. I guess we're through. You should probably say he has difficulty following directions, which means that we could still try to change the routine, the environment, or the caregiver. You also see behaviors with dementia, expressive or receptive aphasia, and lack of coordination. So it's not usually weakness. Weakness is usually a comorbid problem, but lack of cord is more likely what happens with this case. She'll get into a chair if she wants to get into a chair. But if you want her to, that's a different story. That's a motor coordination deficit, a dyskinesia. Or if she's trying to sit 45 degrees away from the place that you're trying to get her to sit, or if she tries to crawl into the chair, and thinking about retrogenesis, who else tries to get into a chair like that? Kids, toddlers, so that tells you a little bit about their processing. And a poor response to drugs. Okay, neuro review. Think of your brain as 3 brains. Hit the mouse brain. Oh my God. I mean, I meant to do that. Anyway, think of your brain as 3 brains. You have your midbrain structures responsible for a lot of autonomic processing, including fight or flight kind of response. Then you have your external brain, which we're viewing right here, your cortex or your cerebrum or your cerebral cortex. They're all different words that mean the same area, so you can just write cortex. And that area is divided into 4 lobes, 2 hemispheres, and that's all executive management function. Then you have the cerebellum, responsible for motor praxis. These are your recipes for movement. Any of these areas could be affected by a dementing illness, so let me get into a little more detail about what the structures are responsible for, and then we'll play a little game. All right. We'll start with the cortex and work our way in. Dementia could affect any area of the cortex. You get right brain and left brain, and each are divided into 4 lobes responsible for different executive management functions. So we've got a pair of each. Frontal lobe, easy to remember. Take your hand like this. See? You go, oh! It's located in the front and responsible for your judgment, your personality, safety awareness, emotional control, like composing yourself. See, I'm crying inside, but this is all frontal lobe ability. Okay? We also see that area is responsible for divergent thinking, correcting mistakes before you make them. Psychologists believe that not everybody's capable of that. That's actually a very higher level skill, like planning for long-term financial security would be an example. It's like, you know, maybe I shouldn't have borrowed money from the mafia. Okay, I'm just kidding. It's my overdraft. Just kidding. Also, organization. I don't believe everyone's capable of that either. In college, I saw people highlight their whole textbook. It's like, all this is important. So that's frontal lobe, and then you have the Broca's area for language as well. And then temporal lobe you could think of as being next to your ears for a reason, highly responsible for language, expression, reception. And then you have the Wernicke's area there for processing time. So Wernicke-Korsakoff syndrome probably has a symptom of time problems, like amnesia, that you might think is 5 to 10 years ago. There's a mini garment in there, so your environmental awareness, symbolism is processed there, a lot of logic. And then you have the parietal lobe located at the top here, responsible for sensory and motor processing and motor output. And that's where the problem is. I ask him to sit, he's trying to execute here. When he wants to sit, he's just tapping into here. Occipital lobe, vision, usually an area of superpower with dementia. The only deficits we're really seeing with vision are maybe later, that you might need to be within 2 to 3 feet of their face for them to process. And then earlier on, we see some depth perception issues, maybe some visual discrim stuff, and spatial awareness. That's why if you turn the keypad on a locked unit upside down, they have trouble getting the code out. So do you. Okay. So that's an area of superpower. And then the cerebellum is also an area of superpower. This is the area of motor praxis. Practice makes perfect, practice makes praxis, and that will stay relatively intact for a very long time. We'll talk about those strengths in a moment. Midbrain. There's this structure called the basolimbic group, which is the very central structure of your midbrain. It looks almost like a walnut. All right? And inside you have the basal ganglion. Most of them are inside, some of them are outside, which are very large neurons which will secrete neurochemicals and transmitters to regulate feelings, emotions, and your body at a subconscious level. Then you have, and that's the fight or flight side of your brain. That's your primitive midbrain, or the basal ganglion. One of your senses hooks up on that side. It is your olfactory nerve. It's the only sense that connects to a different place in the midbrain. All the other senses don't like him because he smells. Okay. Now on the other side, you have the limbic system, including the pituitary gland, hypothalamus, thalamus. Right? And any of those areas could be affected by a dementia. Midbrain kind of runs in binary. These things get stuck in the on or off position. So they'll be just think of zeros and ones for the midbrain. And in dementia, things get stuck. Hypothalamus, for example, it secretes chemicals to help regulate your hunger, your sleep patterns, which we call diurnal rhythm. We'll cover D-I-U-R-N-A-L. Most of your emotions, except for the fight or flight emotions, are at the core there. And then you have temperature, osmotic pressure, which is blood pressure and volume, and sex drive. So any of these could be stuck. And so you get these interesting care plan meetings with dementia because in mid-stage we see a noticeable midbrain impairment, like dementia gets the munchies. Like right after breakfast, she says, "When's breakfast?" That's not just a forgetful question, that's a hungry question. She'll have significant weight gain for about 6 months, and then it's shut off. And she doesn't want to eat. That's part of the dementia. It's expected weight gain. And you tell the family ahead of time that it is coming, so it can be prepared. See, if we didn't even admit that they had dementia, how could we prepare the family for the stage? Okay? So then what do? Well, you don't put them on a diet. The non-farm intervention is to let them get fat. It's like a bear getting ready for winter. This will be a calorie reserve for later when they're not eating. Besides, you can't put hungry people on diets. You get behaviors. What if I dragged someone to Weight Watchers who didn't want to go? What would happen? Right? Well, they'd do just what the client with dementia does. They'd find a supplier, unhealthy foods, they'd grab food off of other people's plates, or they'd tell the state surveyor, "Nobody ever feeds me." And that doesn't go over so well. Okay? So you tell the family ahead of time that weight gain is coming. and maybe buy the next size up in clothing so they could have nice, tasteful outfits, go to the Wabogo sale, have good stuff. Because otherwise, we end up having these conversations that get people upset, like mentioning the S word, sweatpants. It doesn't go over so well. Then when the weight loss happens, there's some other ways to make sure that people eat. But I mean, if the weight gain's only happening for 6 months, I mean, how much could you gain in 6 months? Yeah, a lot. If you have an insatiable hunger, you could probably give chewier foods or something that takes longer to eat. Now, then they start losing the weight, and one of the interesting things about the basal ganglia is that one of the first senses lost with dementia is the sense of smell. And your sense of smell is very important for your survival instincts, but it also helps you taste your food. So with diminished smell, I can't taste things as well. I have a diminished appetite, so probably the only thing you'll see me eating is dessert, because my last taste loss is sweet and salty. What does that mean? What would be the non-pharm intervention to make sure people eat their food if we know that? Ice cream, sweet stuff. Yeah, you got the magic cups, you got the ice cream, and also, maple syrup isn't just for pancakes anymore. I put that on everything. Or chocolate syrup on meatloaf. And then I have someone who comes up to me and goes, "Oh, that's horrible. That's a dignity issue." And I go, "It sure is. You're right. Everyone should enjoy their food." All right? See, I took your word. Retire. Because I feel like sometimes people can't put their feet in other people's shoes. And I say it's a sensory processing thing. And, that's actually cool now. If you look at Food Network, people like chocolate syrup on a hamburger. That's crazy. It's good, Or you get the people up at the Cape. It's like buffet. Wasabi and maple syrup on lamb chops. That's nutty. That's good. Yeah. So, yeah, that's cool now. You're nouveau. Sweeten things up. And what else do we have? Oh, sleep disturbance. We clearly see that with dementia. We see emotions get stuck in on or off. So you might see the person who has excessive emotions, like crying all day. And I have people come up to me and say, "She cries all day. She's always that way." I'm like, "Does she cry all day? Does she cry when she's asleep?" And they look at me and they're like, "Well, no." I'm like, "Well, I'm asking because you said all day." And if I know when she cries, I could find the antecedent to the behavior and treat it. Sometimes, I come across to people as abrasive, but that's just because of the environment we work in. After we talk a little while, they realize I'm trying to help. I go, "Well, when does she cry?" She goes, "Well, probably about a half an hour after I get her ready every morning." Like, oh, so I go in there in that morning and see what happens. She wakes up, she looks at her caregiver, and her caregiver gives her some reality orientation every morning. Every morning she wakes up, she goes, "Where's my husband? Yeah. Oh, he dead. Oh, I didn't even get to say goodbye. She lost her husband 6 times this week." Yeah. She forgets. But physiologically, her hypothalamus is still stuck in on, so she's still secreting "I'm sad," even though she doesn't know why. So what does that mean? I think the non-pharm intervention would be lie. He's at work. It's hard if you were trained in the reality orientation model because we thought, the truth is very important to tell people. But I don't think it's important if there's no awareness of awareness. If I don't know that I have dementia and I'm not in that place where you are cognitively, maybe not. I mean, what would you tell someone who is approximately their cognitive age if they asked something like that? Or maybe you could say it's something that's the truth. I haven't seen him, but if I do, I'll tell him that you're looking for him. Okay? Which you certainly would if you did. I'm sure you'd be surprised. what else? Or you could say, why? What is it that you want? Maybe what's the need driving the behavior? Maybe she has a honey-do list. She always asks for her husband because she wants something done. So you're like, what? I'll do it. I'm here. All right. What else were we seeing for difficulties with the midbrain? Sometimes sex drive gets stuck in on, like with Huntington's chorea. That's a triallele disorder, and each generation gets it younger and younger, more severe, but sex drive gets stuck in on. Some spouses would believe that's a superpower.